do my opening statement. Welcome to this meeting. Okay, that's quite creepy. This meeting has been held remotely and also in person and will be filmed and recorded for live and subsequent broadcast available through the Council's website. The Integration Joint Board is a joint data controller with Inverclyde Council and NHS Greater Glasgow 5 under the UK General Data Protection Regulations and the Data Protection Act 2018. This meeting will be broadcast and recorded to fulfil our public task obligation to enable members of the public to observe the democratic process. Data collected during this meeting will be retained in accordance with Council public policies available through the Council's website. Members of the IJB are reminded they should follow the IJB's established meeting protocols, including around the use of the chat facility, and the comments made in the chat facility are visible to all participants in the meeting, which may include members of the public who have also received invites to this meeting. In that case, if we'll just go on to point number 1, apologies, substitutions and declarations of interest.
We have apologies for absence from Jonathan Hines, Charlene Elliott, Dr. Hicks McDonald and Jackie McIntyre. Chair, we will now move on to a roll call before asking for declarations of interest. And the following members please indicate they're present at the meeting, either in person or remotely. David Gould.
In person.
Councillor Brennan.
Remotely.
Councillor Moran.
In the chamber.
Councillor Quinn.
Present remotely.
Councillor Reynolds.
Remotely.
Dr. Metcalf. Giovanni D'Alessio.
Present in person.
Dr. Paul Ryan.
In the chamber.
Kate Rocks.
In person.
Craig Gibbon.
Present in chamber.
Laura Moore.
Present in the chamber.
Dr. Chris Jones. Adam Smith.
In person.
Kenneth Watt.
Remotely.
Heather Davis.
In person.
And Stephen McLaughlin.
In person.
Are there any declarations of interest?
That was nice and simple. Thank you very much for that. Before I move on to items for action, what I propose we do is take in supplementary agenda item number 2, and this is the non-voting membership of the IJB and Inverclyde Joint Board Audit Committee. Now, Darren, are you going to speak to this?
Yeah.
Thank you.
Thank you, Chair. The purpose of this report is to ask the IJB to agree the appointment of Kenny Watt as the NHS Board Staff Representative Member of the IJB to replace Kirsty Michael. The IJB is also asked to appoint Kenny as a non-voting member of the IJB Audit Committee, again to replace Kirsty, and I'm happy to take any questions.
Colleagues, any questions at all? In that case, are we content for this item to pass and welcome Kenny to? Fantastic. Kenny, welcome. Good to see you.
Thank you very much.
That was a very simple paper. Let me continue. Okay, in that case, if we can move on to the minutes of the meeting of the 12th of January, which is item number 2. Are there any comments or amendments which have to be put in place in terms of the minutes? Looking around the room and remotely, I'm not seeing any. In that case, members, are we content to accept these as accurate recording of the last meeting? Excellent. Okay. In that case, if we can move on to the rolling action list. Colleagues, Tina, do you want to start? Take us through anything we need to know in terms of ADs here. We're going to take this later in the meeting.
No, there's nothing further around ADHD.
Okay. And then in terms of the other ones, are we going to talk about the visitor residential facility for asylum seekers, Tina and Kate? No. Okay, that's fine. We'll do that now, or?
So this has been quite a long-standing action, and it reflected one of the previous IJB members' non-executive interest and some other members of the IJB to meet our asylum seekers, and particularly asylum cells. So we did put out a series of meetings, but for some reason it didn't suit everyone. We just want to ask the IJB, is that something that they would want to visit again? And remember, we don't We're not responsible for operating the hotel. That is the Home Office delegated to mayors. But we will work with our partnership to try and meet. We have a health team that continues to support our asylum seekers, so I'll be looking to make something.
But we should open up. Any comments? Is there a desire to do this? Do you want to take this forward? What can I do? Paul?
Just say yes, basically.
Okay. I see, Robert, you were nodding as well, I think. Or were you nodding as well, Robert? I wasn't sure.
Yeah, I've been in here, I've been over the way, so.
Oh, well, the instruction then in that case. Thank you very much for that, colleagues. Just moving on, we've got the report, the Children and Families Budget Pressures, will be June 26th, also for future meeting. We've had the development session on the ADP strategy, which Maxine and the team delivered to us. Thank you very much for that. So those can both be closed. And then in terms of 3 that are open, I know Jonathan's not here, Margaret's not here. Again, we'll be taking the Lens project that will be in hopefully May 2026. Again, closure of Inverclyde. And finally, the GP services. Is there anything on those we want to comment or please allocate? No, that's at the moment in terms of future meetings.
Still getting the data in for the season, so it'll come to the June.
And then moving on in that case to annual report schedule and for planning. Does anyone have any questions or comments for Craig and the team on this? Craig, do you want to comment? Seems quite straightforward as usual.
No further comments on it, we're content with it.
Excellent, okay, thank you very much for that. And in that case, if we then move on to item number 4, financial monitoring report for period number 9. Craig, give us the good news.
Thank you, Mr. Convener. This is a standard finance report that we bring forward every cycle and it covers a number of main areas. It covers a period 9 projected 25-26 outturn, a current capital position and a reserves position. The paper also gives an update on the progress against the saving targets to date. As at period 9, we're currently projecting an underspend of £433,000 for the combined IGIB budget. Social care budget is projecting an overspend of £457,000 and the health budget is projecting an underspend of £890,000. Obviously, by year end, we will transfer any underspend that we have for reserves and in order to bring the overall position back to a break-even position. As always, there are a number of over and underspends within the overall budget. Starting with the social care side of the budget, the main driver for the overspend is due to the children and families budget, projecting a 3.319 overspend. This is a slight reduction compared to period 7, and this is mainly due to residential placements and child respite overspends. This forms part of the overall children and families redesign that Margaret is currently taking forward. Additional funding from Inverclyde Council as part of our budget process has helped with this review and will help going forward. We also have the use of the non-recurrent pension monies to assist with the smoothing of the children and family budget, and we're using this to help us through the overall budget. We understand this will come to an end at the end of this financial year, and we've factored this into our 26-28 budget, which we'll present shortly. This is also partially offset by underspends within the older person's budget. Looking at the health side of the budget, the underspend is mainly due to vacancies across a number of departments. Prescribing is now showing a 350k underspend, and these are the main reasons for the projected underspend within health. The next section highlights the HSCP's progress to date in the achievement of the in-year savings. And as you can see, very good progress for the delivery of the savings. And further to this report, the IGIB met in December and approved VER releases to assist with the overall final savings to be delivered, and these will be delivered in 26-27. Section 7 of the report shows our overall earmarked reserves and shows we started the year with 17.144 million and expect to finish the year with 14.946 million based on our current projections. Our total general and smoothing reserves are expected to be 6.408 million and represents 2.75% of our total funding. Section 7.2 highlights the number of earmarked requests that we wish to make at period 9, and this is a normal request that we do as we approach year end and covers a combination of ring-fence funds general underspends and smoothing reserves that we wish to earmark for the future years and also help to assist us with our 26-28 budget. Moving on to the capital section, section 9 shows the current capital position in the community hub capital project has already started, and this section highlights what we spent to date. As always, I appreciate there's a lot in the finance reports, but as always, more than happy to take any questions anyone might have.
Great. Great, thank you so much. Colleagues, if I can open it up. Paul, I see your fingers up.
Yes. Take the
I'll rephrase that. Your hand is up, Paul. Thank you very much. Thank you, Kate, for keeping you right. That's Paul really in a public figure.
Thanks for a few questions as ever. Reserves position. I gather there's only one IJB in Scotland reserves over 2%. Does that what I mean? It's us.
To be perfectly honest, I'm not sure, but certainly be at 2.75 would indicate it.
Because there's a national meeting this, I said half of them haven't any reserve spots, so that's very good. Can I ask about the reserves? You talk about the reserves at the moment, the underspend will be put back into general reserves, but then you're talking, does that then go back into earmarked? How's it split up then?
What it would do at this moment in time is it would go to general reserves,
right,
to top that particular one up at this moment.
Okay. And next question, you talked about the superannuation smoothing. Do we have have the rates been agreed for future years yet? Or when does that, when do you know?
No, short answer to that is no. We know what it's going to be from next year, but beyond that, we're aware there's an actuarial review taking place,
right,
which as soon as we know the outcome of that, we'll bring that back to the IJB. I expect to hear that quite soon, so it will factor as part of our report going forward.
Okay, final question is, you're talking the section about the community hub, and you talk about section 52 work. What is that? I have no idea. Section 56 work, sorry, external work. Completion of section 56 work. I have no idea what section 56 works are. It's 9, and that's section 9.2 at the very bottom of the page.
Okay, it's highlighting to me that we think that that's to do with the roads.
All right, okay. It's on. Thank you.
Thank you, Paul. Colleagues, any other questions or comments? Looking around that. Steering.
David.
Oh, sorry, Gio.
Thank you, Chair. 9.2 talks about the delay in the program of the delivery of the community. I'm just wondering about the dates, the files, so if there are any material budget impacts in terms of that, deriving from that delay.
Okay. Through yourself, convener, I'm not aware of any at the moment. Nothing.
Great. Thank you.
Okay, colleagues, I'm not seeing anyone else for anyone else. In that case, if you'll come at that question for myself as chair, if that's okay, Craig. Obviously, we are talking about period 9 here in terms of the position we're now at the business end of the financial year. Is it possible to give an interim update on the 433 surplus? Has that changed at all? Is it going from that direction?
Through yourself, convener, yes. We're obviously working on period 11 at the moment. My initial view of it is the underspend we've got is likely to increase between now and the end. That will obviously, as I've said before, any additional underspend we have will go into general reserves.
Excellent. Okay, thanks for that. In that case, just looking at the recommendations, there are 4 items we need to note and 2 we need to approve in terms of the proposed budget realignments and the specific earmarking in section 4 and 5, summarised section 7.2. Are we content, colleagues, to approve those and to note? I'm seeing lots of nodding. Okay, great, you got off easy there. Thank you so much. In that case, if we can move on to the main item of discussion today, which is the budget paper number 5. Just in a preamble, we obviously had considerable opportunity as board members to actually have discussions and raise questions about what the budget proposals are with exec colleagues. But I'm absolutely open to any questions or comments what we raise in this meeting. I want to be a slow discussion so the members are all happy in terms of that discussion. We've looked at it sufficiently, though it has already had a lot of detailed discussion already. So with that preamble, if you want to just introduce Craig and we'll open up to comments.
Thank you very much, and through yourself, convener. As is always the case with budgets, there's a lot in the report, but I'll do my best to keep to the main points we've got. The IJB over the last 6 months have taken part in development sessions in the budget which has led to this final budget. I want firstly to thank everyone for coming to these sessions and for all your contributions that you've had. Similar to previous years, and in line with what our partners in Inverclyde Council have done, we've been very keen to produce a 2-year rolling budget. We feel this gives us the opportunity to build some certainty into the budget process and also give us the opportunity to do some medium-term financial planning. Since the summer of last year, the SNT have been working on the financial gap for the next 2 years. The main driver to the gap is seen in the report is addressing our long-term funding issues in children and families, prescribing pressures, social care pay and work funding, and demographic pressures. We've done this, and sections 4 and 5 highlights that we have a 2-year funding gap of 6.493 million. Our financial settlements from both the Health Board and the Council are detailed in the report, but I do want to highlight that both partners have passed over all relevant funding to the IJB. Inverclyde Council, in addition, have also supported us with additional recurring £800,000 to assist with the review of the Children's Services redesign. This is in addition to the recurring £700,000 provided this financial year, and a further commitment of £500,000 recurring for 27-28. This gives a total £2 million recurring investment over a 3-year period. I wanted to thank Inverclyde Council for this and their continued partnership working with us. As is always the case, the SNT have been keen to protect the frontline services and staffing levels as a priority. We feel this budget today meets those objectives. Since the summer, the SNT has developed a number of proposals to close the overall gap, met with our partners at Inverclyde Council and NHS Greater Glasgow and Clyde, held a number of development sessions, staff side and our savings programme board in order to present the report we have today. Section 6 of the report and appendices highlight savings that have been developed and are summarised as is £3.2 million budget adjustments, £1.8 million worth of efficiencies, £1.3 million of service reviews, and £0.2 million of increased charges. At this point, there are no plans to carry out any further voluntary releases or voluntary early retirement exercises. IJB members have already seen detailed savings sheets and equality impact assessments on each of the relevant savings. These savings are phased over the next few years and will initially require temporary use of £757,000 of reserves in 26-27. This will be repaid back to the budget in 27-28. Section 6.4 highlights some of the risks we face over the next few years and will obviously bring updates back to the IJB as these develop over the few years that we're talking about. Section 7 highlights our current reserves position along with Appendix 6. The main area is always to focus on the general and smoothing reserves. And we still have nearly £6 million available in this area, and I personally think this is a really strong position for us to be over the next 2 years. Section 8 highlights the medium-term financial plan. Early indications are that we'll have a further £4.5 million recurring gap by 2031. The work will commence over this in the future. Before I move on to the recommendations, I want to say a special thank you to everyone from the IJB for their help over the last 6 months in developing the budget, the SNT and the service managers who have helped and worked so hard in developing these proposals, and our partners in the Clyde Council and NHS Greater Glasgow and Clyde. I personally want to say a huge thank you to Sam White, who's with us today, and Helen Burke, who's with us online, and your finance teams who have been the soul of this exercise. It's always greatly appreciated, your work. I just wanted to highlight the recommendations today, asking the IJB to note both the funding contributions from both the partners, being Inverclyde Council and NHS Greater Glasgow and Clyde, ask the IJB to formally give delegated authority to the Chief Officer to accept formal funding offers from both partners, agree the net revenue budgets as highlighted in the report. In the report, there's a slight issue with some of the numbering, so I'm just going to highlight that and say it here. Note and approve the savings identified in Section 6. Note the reserve position in Section 7. Approve the updated financial plan contained within Appendix 8. And as always, I'm more than happy to take any questions anyone might have today.
Great, thank you so much. Colleagues, I will open it up. And Paul, you're in there again.
Sorry.
No need to apologise.
First of all, commending the paper, a lot of excellent work done, you've done a lot of work already. I think having the budget over 2 years makes planning so much easier from the end. Couple of questions, however, as ever. Pressures we're talking about coming. The reduced working week starts for the NHS in April. Okay, you've got pressures already for banding, going from banding 4 to band 5, which I think is mainly covered. I've discussed with you earlier. There's pressures about going from band 6 to band 7, which are not completely, which I gather you fed into that. I've got a few other questions that I want to deal with them first, perhaps.
Yeah, more than happy to do that. You're correct. The band 5 issue, band 5 to 6 is covered with government funding that we have. The 6 to 7 isn't covered, but what we've done is we've put a £300,000 earmark reserve over the next 2 years, which will allow, and this was approved at last IJB, and that will give us the time to build and do a service redesign in that particular area.
The reduced working week, we fully covered for that.
The vast majority of it is, but you're probably aware we're only getting 75% funding of that, so we will need to work over that in the coming months to ensure that we can maximise that within the envelope that we have.
Okay. So,
If I could come in, we have a shortfall in community nursing that we've asked the board to give us a 75%. I think there was a misunderstanding at the time when the money went in. People thought it was only for acute delivery as opposed to community delivery. So we're in the process of asking for a review of that decision making.
of which band are we talking about, sorry?
Community nursing
In general?
in
Okay.
general. I think it's working out to be about 120 grand short, I think.
It's a wee bit higher, it's about 200,000.
200,000, okay. So we've asked the board to see if they can cover that. Some HSEPs have been given the money, but and some haven't. So, and that was really not to do with the board, that was to do with the misunderstanding about what could be requested on from the first instance. So we asked for our situation to be reviewed.
Two other questions, I'm afraid. Sorry. You mentioned in your paper, NRAC, the National Resource Allocations, so the board's got 30 million cut, but that's not going to affect this year, it's next year. And what's planning for that?
So you're absolutely correct when you say that in the report as well. There is an NRAC cut from the health board side of things. At this moment in time, it won't affect 26-27. Potentially for 27-28, but we've not had those discussions yet with the health board. That's why we identified it as a risk in the actual paper. Obviously, there's been no more about that. We'll bring that to the IJB, but we haven't had those discussions yet with the health board around it. But all the other IJBs in the exact same position with us.
Yes, sir. And finally, prescribing is always a big one. There's a long chat with Hector, who's quite comfortable with the situation with all what's been done in it there. But it's very volatile. That was even before things kicked off in the Middle East. So there. So, but you have some. You're not using your prescribing reserves this year. Is that right? But you're holding on to them.
No, you're correct. We've still got just shy of £1 million prescribing the earmarked reserve to help us in that area if we need it.
Thank you.
Thank you, Paul. I'll open up any other colleague. Robert.
Thanks, Craig. A great paper, I have to say, and I looked at the local paper today. It says that this budget was about cutting and affecting the most vulnerable in our society. I'd like to record that we are not here to attack anybody in our society. We're here to do the best we can with resources at our disposal. And I know we can all blame each other, Westminster and Scottish Government herself. But at the end of the day, we're the people that have to deal with this. So it's a real good piece of work. And I think it's important that we thank the head of services who do all this work to come up with this plan that we see here now to make sure that we don't affect the most people in our vulnerable in our society. We do make sure that they're protected. And this is what this budget's about. It's not about cutting, it's protecting people, protecting jobs, protecting people who we represent. So I want to thank everyone for that. My only comments would be is the ones that Paul said there. I mean, who'd have thought we were going to have a war?
Yeah.
And the trouble that put us in. And just looking at you say there, the prescribing budget is volatile, I wouldn't get worse. But that means that all our services will be experiencing some pain along the line. If that's just a heating, central heaters, whatever we do. So I just wondered, you know, we have got a wee bit of reserve there, but do we have any connections, or is there any extra help coming from central government with a city slash development?
Through yourself, convener, at this moment in time, I'm not aware of any additional support from that.
Thanks, another thing, yeah, but I think it's one before you, sometimes circumstances overtake, but I mean, that's Peter Paul, we need to be updated again quite soon, you know, that's just the way the life is, you know, but anyway, thank you very much, it's a good piece of work.
Thank you for that, Robert. Any other questions or comments, colleagues? No, I see anyone online and nobody in the chamber. Craig, it's probably just reflecting that point that Robert raised in terms of the importance of reserves, because if you are a user of the service, it can be quite difficult to reconcile the fact we're having to make savings with the fact that we've still got reserves as well. So it might be worth just saying why reserves are so important. I think Robert's already alluded to it, but maybe making that explicit would be good.
Yeah, happy to do that. Reserves are there. Hopefully, so we don't actually have to use them. And we always try to do it as an SNT to bring forward savings that actually can deliver the requirements of what we're doing. So the reserves are there, but they are very important. We will only use them if we really need to. And as I've said on a few occasions here, we are in a fortunate position. I could say fortunate, but no, that's all the good work that's been done by the IGIB and also the SNT that puts in that position.
Kate, you want to come in?
Yeah, and also the most important thing is that we would use reserves where we know that it has got significant impact on people and the delivery of people. So we need to bring the human bit back in.
Thank you for that. Okay, I'm just last call for any more questions, comments. I'm not seeing any. In that case, if we look at the recommendations, fundamentally there are 9 there. The most important is we are seeking to approve the budget. I'm going to look around the room and online and ask are there any dissenters who do not wish to approve or we intend to approve this. I guess the case of speak now or forever hold your peace. I'm looking around, I'm not seeing any. In that case, I think we can take this budget as approved. Thank you, colleagues. And can I just say thank you, echo many of the sentiments expressed in the meeting. Thank you to Craig and the team, the entire executive who's involved in getting this position. It has been very much a team effort. Nobody wants to get in a position of having to make savings, but the focus, as Robert has said, and Craig and Kate alluded to, in terms of focus on the most vulnerable and making sure we do the most we possibly can with the available resources we've got is very, very important. It's always worth just reiterating that point. But excellent piece of work. Thank you very much. We can take that budget as approved. Okay, in that case, if we can then move on to agenda item number 6, Inverclyde HSCP Workforce Plan 2025 to 2028. Can you yourselves speak to this?
Obviously, I'll introduce it and I'll introduce Angelina, who has done much of the work in trying to bring this all together. This is an important part of our strategic plan and how we deliver our key priorities by developing our workforce. I think that one of the challenges is to ensure that we've got harmony between the council's workforce plan and the NHS, and Angela's done a great deal of work in that space to ensure that both organisations would be able to see themselves within it. I'll hand it over to Angela.
Thank you, Kate. Thank you, Chair. The plan represents our next 3-year cycle from 2025 to 2028. At the IGIB in June 25, we had said that we had to develop the new 3-year plan in line with our strategic partnership plan, and we agreed that we would bring it back here by the end of the financial year. So that's the reason why it's 25, 28, and 2026. The plan has been developed collaboratively with the Workforce Planning Group and their senior management team. Our Workforce Planning Group consists of staff representation, third sector, and a great cross of managers across the whole of the HSCP. The plan responds directly to key pressures facing workforce, such as age profiling, absence, challenges, well-being, recruitment, retention, etc. And we've made sure that it aligns with our current employers' workforce strategies. The accompanying action plan, which we would be looking to bring back to the IGIB every 6 months to provide a progress update for you, has been developed in line with the NHS Scotland's 6 steps process and also NHS UGC's pillars of safety and wellbeing, culture and leadership, learning and careers and recruitment and retention. Members are asked to approve the workforce plan, notice publication externally and agree the direction to the Council and the NHS UGC. Thank you.
Angela, thank you very much. Colleagues, I'll open up. Any questions or comments for Angela, Kate and the team? I'm not seeing any. Okay. Oh, go up, Becky, go for it.
Well, I still really answered 2 of my questions. So yes, so thank you. It's a good plan and it's really welcome. Thank you, very welcome.
Angela, I think you're going to get off quite lightly here. I'll just echo that comment that Becky made. I think it's excellent. It's really good to see also in terms of the progress that's being made already. I think all but one are on target. If you'll allow me just one question in terms of, I think it's objective 2 and workforce pillar 4, recruitment and retention. I wonder if you could expand a little in terms of what we're intending to do in terms of pilots so that we can enhance our recruitment and retention activity. I think that's on page 19. If that's good, I'm not looking for chapter and verse with a little bit more detail if that's possible.
Sorry, I had to remind
No, that's okay. No, absolutely. I mean, if you could do it off the top of your head,
Sure.
that'd be more than we would expect. That would not be reasonable.
So this objective would involve us working with our parent employer, OD and HR colleagues. The NHS is focusing quite a lot on recruitment retentions regarding Grow Your Own schemes. We're also doing some local ones as well, the social work ones, and we're going to expand that. And then there'll be some on the council side, which is a newly established OD team. We'll be working with them about doing some statistics about the recruitment and also the community figures and seeing where we can go regarding extending modern apprentices and graduates.
Angela, thank you for that. I'll just see if there's any questions from. Oh, Gio, come in.
Thank you very much for the report. It's very detailed. I was asking myself, in the previous report, there was like an amount of underspent just due to basically posts not filled, right? And then we also know, the level of absences that we have is like, so I'm just trying to figure out what's the level of staffing that we are comfortable with that we can operate, knowing that we are going to have those constraints, because I don't think that those constraints will go away, right? So have those constraints been factored into the plan already, and how do we respond? Do we have like a backup plan for action or situation that we know are going to happen?
Thank you very much, Chair. We have the Health and Care Staffing Acts that the Chief Nurse and the Chief Social Work Officer have oversight of. And there is an analysis that's done to check if we've got safe levels of staffing, and then there's contingency plans brought into that. Also, our corporate workforce information comes from corporate HR departments, and they let us know about age profiling so that we can start to plan succession planning and address any gaps that are coming our way. Hopefully that answers the question.
Thank you.
Gio, Kate here.
So just to add to that, we're really, really thoughtful about the impact that not only our recruitment and retention has, but our succession planning. And so over the next 2 years, are going to be thinking really thoughtfully about how do we develop the capacity because of the age demographics within the HSCP, and how do we create the succession for the future. That's across the board. That includes our business support. We know, you asked a question earlier about AI. If we fully embraced AI, we would find that our business support complement might not be required in the same way. So we're wanting to get ahead of the game and try and work out what are the posts that we need. The ones that we have deleted are the ones that are hard to recruit, and very few of them have been operational, the more strategic facing. So we've been able to bring together more connections across the HSCP. So an example of that will be bringing health improvement into your strategy team to deliver our strategic plan, because if you don't have health improvement in the middle of that, now that could have sat elsewhere and went off and worked to a different priority. So it's about streamlining and prioritising, but also seeing the opportunities that we can grow a different skill set, because we're going to have a different skill set moving forward. Jane.
Thank you.
Intent, Gio?
Yes.
Excellent. Okay, I'm not seeing any others. In that case, colleagues, if we look at the recommendations of the report, are we content to approve this final draft of the workforce plan and note the progress that's been made? I'm seeing nothing around the room. Dave, hands on the team, great job. Thank you for that. Okay, we'll move on to agenda item number 7. This is looking at Inverclyde's HSCP's contribution to unscheduled care. I presume you're going to introduce them more in the speech to this.
So we had a discussion as a senior management team that we had been bringing bits and pieces of data over the last year about our contribution to unscheduled care, and I think overwhelmingly that heads of service and chief nurse and chief social work officer felt that we might want to bring all of that information together to provide a level of assurance so that you can understand the strategy and the direction of travel, and that this is a bit about how we do it as opposed to the data. So I'm going to hand it over to Laura, who has pulled all this information together, and she'll take us through the report.
Absolutely, thank you for that, Kate. So really the report gives you an overview of the key contributions, including the sort of enhanced community responses, the targeted prevention initiatives, and the multidisciplinary collaboration and sort of digitally enabled work that we've been doing. So a significant amount of work goes on under the banner of unscheduled care. But really these actions are all helping to reduce pressures on the front door of our acute services and strengthen alternatives to hospital-based care and really improve the experience of those who are out in our community. And also the outcomes of them. We know that being in acute care isn't the best place for people, and being able to keep them in their own homes or get them back there as soon as possible is absolutely key to all of this work. So we've laid out for you in the report some significant information about the sort of key updates and successes. And just pulling out a couple of those, you can see that through the intermediate care and frailty at the front door, we've saved significant numbers of bed days for all of those individuals, and that we've actually managed to keep people at home and prevent them going into hospitals. One of the latest pieces of work that we've put a lot of work into was a community appointment day, and we're hoping to do a lot more of these. You'll see that in the next steps. This one particularly was a little bit of a flash report there with more detail for anyone that wants it. But we had 129 members of our local population register who came along to the event to talk about their severe and persistent pain. And actually the feedback we got from them was absolutely fantastic in terms of the fact they felt listened to, and they went out feeling much more confident about the plans that they had to be able to look after their own pain as they move forward. In terms of the virtual ward, we've talked about that before. At the IGB, that continues to work exceedingly well, continuing to keep people in their care homes for their palliative and end-of-life care. And we've also got some information there about COPD and the work that we've been doing with remote patient monitoring. So again, keep people at home. And that work really started from looking at people who were bouncing in and out of our A&E departments, and how could we help them to be more empowered to look after their particular disease at home. And we can see from that we've had an 80% reduction in admissions and a 64% reduction in bed days. So significant work going on there. In terms of next steps, there's always more to do, and there's a lot still going on with the transformation agenda, but particularly looking at how we continue to do more of those sort of CAD type events, looking at frailty at the front door, and looking at our future care planning and how we work across our system to be able to share information in terms of future care plans and have those conversations with people, and also look at scaling up our remote monitoring to wider than COPD. We did mention last time that we were desperately trying to get the money in place to be able to start expanding our OPAT, outpatient parenteral antimicrobial therapy, and that work has now commenced. So we're really pleased that that's been able to start. Only a couple of patients so far, but it only started a couple of weeks ago. So really pleased with that. So in terms of the recommendations, we really want to present this paper to sort of note the contents of it, and so that the IGB hopefully see the significant amount of work that's being undertaken to develop community-based support and prevention initiatives, those alternative care pathways. And we would like support to continue this focus on early help and integrated working, and hopefully agreement that we could bring some of this back again in the future to keep everybody up to date on it. I'm happy to take any questions.
Laura, thank you very much for that. And Kate, we're also able to take some work underpinning it. Colleagues will open up. Questions or comments? Robert?
It's a great report, you know, and it definitely says that no additional financial requirements are needed at this stage. However, should the IGB support the continued expansion of the post described, particularly further development, there may be future cost implications. So, future cost implication, what we talked about here, you know, I mean, it's a bit, believe me, you know, we talked, since it might be need more staff or whatever, as you know, but obviously it's not costing it on, but successful and going forward, it will have a cost implication. To any idea what that would be at a stage?
Thanks, Robert. Bring in Kate.
So when we do something different and you use different skill sets and different ways of working, it doesn't always cost us. You know, it doesn't cost. Sometimes it can create an efficiency. We have money in reserves that if we felt that we required, it was making such a big transformation into delivery service, and we were seeing the impact of that, particularly across the whole system. We would put a business case together and take it to the senior management team and agree whether that's the right report, a way forward, and then bring it to the IGB.
Aye, that's fine, Kate.
Thanks, Kate. Paul?
Thanks, Matt. Thanks for that very much. It's very detailed. I think maybe a few questions, maybe pick up Robert's point first and foremost, but funding and so on. Do you still have access to the Health Board's Unscheduled Care Fund? Does that money fund any of this? No. Okay, fine. A few things then. The report then. ISO, what exactly is ISO? ICI, I couldn't find the acronym.
Inverclyde Centre for Independent Living. Inverclyde Centre for Independent Living.
Where is it based and how does it work exactly?
It's all based at, do you want to come in?
It's based at the centre's based at Gibbs Hill, and that's drives a lot of our multidisciplinary team AHP working, and it's also got our joint equipment stores based there as well.
Does that single point of contact?
That will be brought into as we go towards our integrated front doors. That's one area that we brought into that.
Okay.
We've got 4 referral routes and we've already taken it down to one.
That makes sense.
Okay.
You talk about bed days saved and so on there, and does that count towards, there's a Health Board this target, you talk about virtual, do these count towards the Health Board's target of virtual beds?
Yeah, we report all of that in, so they don't count as virtual beds, they count as bed days saved. The virtual beds are separately counted by interface with the work that they are doing around the word's gone from my head. Can't remember the name of it. The brand new integrated work that's all going on at the board for interface is counted differently. So these don't count towards that. They just count as bed days saved, but we do report them in as bed days saved. So yeah, they're counted.
You must have been very confused what actually counts as virtual beds and what the bed days was.
It's all very confusing. It is very confusing, and virtual wards and virtual bed. But yeah, the virtual beds, the board are looking for 1,000 virtual beds to be in place by August, and they're currently at 200 and something. But that's counted very differently to make sure that there's never any double counting.
Yeah, and just to add that this is more nuanced around our relationship with our care homes and our hospice.
Yeah, absolutely. The word I was looking for was was FNC plus.
Oh, yeah,
That's
okay.
it. Sorry, that just took a long time
No,
to
it's
come.
It doesn't roll off the tongue.
I think I'm looking for a new name for it, actually. Can't-
Don't use
it. For obvious reasons. Yeah. So a couple more questions, if you don't mind.
Mhm.
Frailty, your frailty board, how's that working? Your frailty service?
Yeah.
Can you say a few words how
So
it's
in
working?
terms of frailty, there's a clinic at the front door of the IRH,
Mhm.
which we have a AMP who proactively works there, but who's also provides us with our comprehensive geriatric assessments out in the community. So she works across both areas. That role is just and no more vacant, so that will be getting looked at and recruited into. But in terms of the frailty, really, I think nearly all of this comes under the frailty banner, because these are frail, elderly, vulnerable people. And what we're desperately trying to do is make sure that they're always in the right place at the right time. So I think, I think frailty covers all of this work.
Final point. Sorry.
I was just going to add,
Five hands.
I was just going to add that a lot of our frailty work is in reach to the hospital, which is really, really important. So we're not actually waiting for referrals to come out, as Paul, we're proactively going on the wards and sourcing people that are for the assessment, and I think that makes a difference.
Final question.
Sorry.
I just wanted to add a little bit to what Kate said about reaching out to the hospital. We're also trying to have admission avoidance. So our teams are up in the emergency department, trying to take people out before they're admitted into intermediate care or into more suitable areas in the community for ongoing assessments. So I think that's a really important point around that admission avoidance.
And then final point. You mentioned that the outpatient antibiotic therapy started. Where's it actually? Is it being based in IRH, or where is it actually being provided from?
So at the moment, the expansion of the service we're doing is all provided by the acute team. But what it is for Inverclyde is that those individuals who are on the pathway can come into our local treatment rooms in order to have their lines cleaned and their bloods taken. So people weren't even using Opatin and Inverclyde in many situations because of the fact that we're going to have to drive to and from the QE to have some of that undertaken. So this is really just the supportive starting point to it, so that people still go and have their IVs in the acute, but we do all that line care and all those bloods and all those results go straight back into the acute team. So it's really collaborative working with them.
Gio.
So very detailed reports, and it's just a question about, and again, you'll know that relatively new, I can't use that word too often. There is quite a lot of good KPIs, I call it, from the system perspective, right? As a provider perspective, we get a lot of emphasis. I really appreciate the perspective of the patient, from the persistent data, the direct feedback. And I even wondering or encouragement if there is the opportunity to bring forward more of the patient outcome in the future, because, there is a lot this is what it means to the system, but it's actually very good when you can see this is what it means to the people actually benefited from those changes. There is actually a corollary of that, but not always come true. And, it was really good to see the direct. It really made a difference. There were few words that really resonated with myself, being a patient of chronic pain and so forth. And so it really is actually really, really, really good. So.
Thank you. And absolutely, we've got care opinion that we use in order to capture our feedback from our patients and those who experience our services. And we get a lot of really good feedback, but you bang on that we could have put some of it in that paper. So yeah, we can maybe make that connection for next time, absolutely.
Any more? No? Okay. In that case, we have... Sorry, Sandra, apologies. I did not see a hand up. Come in.
That's okay. I just have a comment. I really enjoyed reading this paper. It was good to see this report, which sets out a huge amount of positive work in key areas and producing really positive outcomes. So it looks like a really good basis for moving forward. So thank you very much.
Thanks for that, Sandra. Okay, colleagues, I think take it this is a very well received report. I think we intend to note the recommendation and absolutely recognise the important work that's going on here. I think from my perspective, just reading this report, what it really highlighted to me was how hospital was not always the best route. A&E is such a well recognised route and it's such a well established brand, for want of a better phrase. I hate to call it that, but everyone knows about A&E, whereas there are other interventions and support that we can put in place that are actually better for the people we're looking after. I think that really comes through in this paper. So just to say, from Chair's perspective, excellent piece of work. Keep doing what you're doing. I look forward to this coming back to this committee. Okay, in that case, colleagues, if we can then move on to agenda item number 8. Kate, your Chief Exec's report.
So it's quite self-explanatory. It picks up from the unscheduled report in that obviously got a bit more of a summary around our 2 new discharge options that we've put in place, our intermediate care, which is our intensive support, including rehabilitation and long-term planning. Because of our situation around our capacity with our nursing home sector within Inverclyde, it forced us to rethink what our strategy would look like, and we decided to do a small test to change around home-based intermediate care, which is not care at home. It's care that you would get you would stay in your own house, you would be rehabilitated by a community rehabilitation and have more intensive support services, a combination of home support and nursing services. And it is shown that very, very successful. So actually, now I'm going to be clear that the 1,773 additional days, we don't count that in the health board, but we do count it in the HSCP, and that is about the people that have been avoided, and we've been able to keep them at home through rehabilitation equipment and technology. So that is probably one of the things that we want to look at. This was our priority, and it would have been the priority across Scotland, is for people to be kept in their own homes. The pandemic came along, we changed our direction because we had no choice but to change that direction. So this has given us a real strength that, on an evidence basis, this is what our first offer should be, as opposed to intermediate care at home, intermediate nursing home care, for people that want it. And you can also see here that the difference around the maintaining or improving their functional abilities between people that are in nursing home care and people in their own home is 1%, so it's negligible. So this is certainly an area that we want to be as growth. And I would just want to say that the frailty at the front door, what Katrina has highlighted, and Laura, is that we've kind of exceeded our targets quite significantly. We had a monthly target of 304 days, bed days served, and we're sitting at 468. So the strategies that we are employing to get people out of hospital or not getting people into hospital are working well for us. And just to say that we were part of the reset in November, December and January, but we were able to focus on where our priorities lay in that time. And I think that serves us well, because I think there's a view that 6 HSCPs are going to be all the same in terms of what their priorities, and they're not. And they're all in different stages of development. And, you know, I always say we can touch the sites, we know where the walls are in Inverclyde. So that makes a big difference in terms of some of our improvements. The next one is just to note, from a governance point of view, of the national review of the group-based child sexual exploitation, abuse and exploitation, and that the Scottish ministers have formally requested a national review into this, and it's led by the Care Inspectorate and HMIE His Majesty's Inspector of Constabulary and Healthcare Improvement Scotland in HMIA. The first phase is really about evaluating the Chief Officers Group, which is the HSEP 6 as part of that, and hosts a lot of the Child Protection Committee activity and the Adult Protection Committee, and Inverclyde hosts MAPA. And so that's based on the children's sexual abuse and exploitation. And phase 2 is a risk-based, flexible and targeted scrutiny approach to identify strengths and areas of improvement. And then phase 3, which will take us up to autumn, will take us up to the beginning of next year, will identify areas of improvement and highlight where these are nationally or may require a national response. And the report is due to be published in autumn 2027. We didn't get much time for this, and that we're in the process of gathering the information. I think our return is due back in the next 2 weeks, and the Chief Social Work Officer is coordinating the phase 1 return. The other thing is, just to note, you'll have seen it, I believe it was on STV News, as our Community Matters bags. I didn't know that, someone told me that. And this is again the strength of our strategic partnerships for our third sector forum in developing these bags to target people that are coming out of prison or who may have been subject to the criminal justice system. People are asking, well, why are you getting a mobile phone or a large multi-use flash? You know, it seems to be quite random. But interestingly enough, it was actually people themselves that told us that that's what they would find really helpful, a hot water bottle and a power bank when they come out of prison. They might come out with their discharge grant, but these things are really, really practical things that make a difference to their lives when they first come out. So again, it's about that trauma, understanding the impact of trauma and that compassionate approach that Inverclyde is so good at doing across all of the agencies and partners across the and faith communities as well. So that is just the highlights of the Chief Officer's report that hasn't been didn't require a substantive report.
Okay, thank you very much for that. Any questions or comments? Sandra, is that a legacy hand before I bring in Robert?
It's legacy, sorry.
That's okay, thanks, Sandra. Robert?
No, once again, great report. We're obviously big emphasis on digital care now and looking after people in the home because that's where they want to be, basically. So, I mean, going forward, Steve said this right, but do we have any conversations with ourselves regarding, especially adoptive flats with all that stuff? Is there anything in there? They take them in and then sort of go order, get it fitted, or someone can just say, okay, we've got a place, you can put it in the right away. If it's there you need. So I don't know if you can answer or Stevie answer, but it's just something.
Right, I'm not going to answer. I'll hand it over to Maxine, who's still in that head of homelessness, and then Stevie, if you want to help us out too. Don't know who wants to go first.
Me. So,
Who's head?
So it's maybe just everybody can come in on the sort of broader strategic goal and function around that, but I'm really pleased that you brought up that digital sort of innovative approach. Katrina and I have literally just this morning had a leadership development session with all of our service managers and team leaders around digital care. And actually Katrina and I have both said that we were probably expecting to go in there, maybe feeling a wee bit like we were pulling teeth a wee bit, but we were really pleasantly surprised. All of the service managers and the team leaders are really engaged in that digital focus moving forward. In terms of we had some really good presentations this morning about how digital care is not just for low-level needs. We've got some really good examples in Inverclyde about how that's the tech is supporting people with really complex needs and actually achieving better outcomes than we would normally with some of our more traditional routes. As we were leaving the session this morning, I had a chat with one of the providers who's really excellent in terms of delivering and really personalising the care planning for digital with people, and really talking about how we use this across our broader sort of work plans around housing, those with, you know, sort of real complex needs in terms of to sustain their tenancy and prevent homelessness, but also across our alcohol and drug recovery services as well. So there's some really good, I came out of there quite buzzing actually with some of the ideas that was floating about in that room. So I'm really glad you picked up on that, because moving forward, we absolutely will. We've kind of got settled into this sort of using digital to support learning disability. That's really quite well established. We need to take it and some with older people's services, but we need to start thinking about how we deliver that across our broader strategic priorities in terms of housing, alcohol and drug recovery services, etc.
Steve, we're trying to treat that thing.
Yeah, thanks, Chair. I think Maxine's put it better than me, and I would have come in. As housing providers, we want people to remain in their homes as long as possible, as independently as possible. I'm a great believer in tech. I can think back at, I've been doing this for a long time now, and I can think of a number of occasions when tech would have made a difference to people's outcomes, and if it would have been available at that particular point. I think also as housing providers, we have to ensure that when we're getting into an adaptations funding, we're spending that appropriately, we're spending it all, we're engaged with the Centre for Independent Living, we're working with the OTs and making sure that there are other options. Some of this work probably overlaps with the local housing strategy and outcome 3 in terms of improving outcomes for people, and I won't go over that because it's different work, but it does overlap, and we need to think differently. We will all need to think differently in the future about how we do this, and the tech that's coming in is making a real difference to people at the moment, and I want to start rolling more of that out, so we will be having these discussions.
Good. Katrina? Thanks, Steve.
I just wanted to say that it's not always about providing an adapted flat, but actually responding to the individual. So it doesn't matter where they're living within their housing stock, that you're able to put that technology in, and it's quite mobile, so it adapts to your need. And we heard this morning about one such instance where somebody started off with a really high level of complex need and quite comprehensive tech, and sort of 5 or 6 years down the line didn't need any of it. And I think we need to be able to be responsive to that, so that they don't then become, for want of a better word, a prisoner within that environment, because we've adapted that house and it's all permanent, if you like, or that they're having to move on from that house because somebody else has that level of need. So I think we're approaching everything that's available out there, and you're right, there's huge advances in what is available and how mobile it is and how adaptable it is, and really built for service user and patient need at the time.
Thank you, Katrina. Robert, Paul.
And a different subject altogether. Can I ask you about the National Review of Workplace Child Sex Abuse and Exploitation? How does that tie in with the Scottish Child Abuse Inquiry? I don't think it's supported yet, so I'm a bit puzzled as to what's going on.
First of all, we were told that it was an inquiry, but it's now an inquiry and a review, so both are run in parallel. And the Scottish Child Abuse Inquiry is in the main around historical sexual abuse. This is about sexual exploitation of children in the community, either group-based or targeted through criminal, commercial, or but this is focusing on sexual of it.
Thanks, Kate. Any other questions or comments? Colleagues, Gio.
And it's not for where I need a response today, but I was thinking about tech. That's where I come from, my industry, right? And so if you look at like biotech and the consumer, shows in Vegas, year on year is keep increasing. It's bigger and bigger. So I'm just curious about how do we make sure that from an HSCP perspective we have staff have the space to explore and then, introduce this type of thing, because I mean, I'm hearing some really enthusiasm, but there has to be also the overall, if you like, framework around it to make sure that actually gets introduced. And
We do
your
have a
answer,
framework.
great.
No, we do have a framework about it. We have a specialist post in the HSAP for digital, and we have a digital cell, a tech flat, and you're more than welcome to visit it, Gio. So that flat will show you how you can support someone 24/7 in the community. We also have the provider that does the remote digital, our provider that Maxine and Katrina were talking about, they're also based there and with their out hours, so it's become a bit of a hub. So if you want to come and down and see it, just put on a time and I'll take you to it.
That'd be great. Thank you.
Just on that note, number of us have had the opportunity to see you and truly impressive. So if you feel the need, I would say absolutely go and see it. It's really good.
Fantastic. Thank you.
Okay, colleagues, in that case, I think that rounds up. Oh, sorry, Becky.
I just wanted to ask you about the intermediate care and frailty services. Like, I know that they were funded through the transformation funding. Is there a risk that won't continue? Because obviously it's really good work for lots of people.
Yeah, we're just looking at that now. Some of the money did come through the health board, and we're not sure where that funding is currently sitting and what we're going to get from April onwards. It's dependent on the Scottish Government. But like anything, we will go away and look at what we're delivering and what we can find and within our own resources. If we're seeing a significant evidence base, or we will try and get the money elsewhere. We will report back if we can't get it.
Okay, thanks, Becky. I'll just make sure everyone's had the opportunity to ask questions. It appears so. In that case, Kate, thank you very much for that update. That was a really useful discussion. I think that concludes the public section of the meeting. So we'll now move on to the private